Department of Hematology at City of Hope. Dr. Pourhassan earned her master's in health administration and management and her medical degree at Rosalind Franklin University of Medicine and Science in Chicago. She began her postgraduate training with a residency at Hennepin County Medical Center in Minneapolis, during which she conducted research into stem cell transplantation at University of Minnesota. Dr. Pourhassan then served as chief resident at Riverside Community Hospital and clinical instructor at University of California, Riverside. She has completed fellowships in oncology, hematology at Loma Linda University, and in bone marrow transplantation and cellular therapy at City of Hope. So with that, I will hand it over to you, Dr. Pourhassan.
Wonderful. So first of all, thank you so much for having me here today. I'm going to do my best to get through this slide deck. A claimer beforehand is that most of these were actually handed to me, and the rest of them, the ones that have the cartoons, are some of them are mine. But we're going to kind of just freestyle it together. I think it's important that a lot of the information on the cards can be a bit overwhelming. So I'm going to try to sort of simplify as much as I can, and that's why questions definitely throughout the process are very much welcome. So the topic for today, there we go. First of all, I have to give disclosures, which is, thankfully at this point in my career, I don't really have much for disclosures just yet. So there's not any financial relationships or affiliations or anything like that that I need to disclose at this time. And today we're going to be talking about CLL, SLL, which is sort of its own entity, in addition to CML. And these are two very different types of leukemia. And I tried to sort of regroup the slides a bit so that we can start off talking about sort of the brunt of one and then the brunt of the other. And then we'll kind of group the two together toward the end in terms of some of the other resources. But some of the things we'll be going over are just simply the symptoms and diagnosis, communicating with your healthcare team, some of the options out there in terms of treatment, clinical trials, etc. So first things first, tips for living in this strange new world. There is going to be so much going on whenever our patients get diagnosed with a new diagnosis. You're having a whirlwind of things going on around you, and of course it's quite stressful. So the first thing I always tell patients is that knowledge is power. So the more knowledge we can give you, the easier it is to navigate and the less scary this world will be. And that's sort of what we're trying to attempt here with this presentation. So first we'll start off talking about chronic lymphocytic leukemia. Now, this is an entity that's a little bit of a misnomer in that it has two words kind of that are differentiated. One is lymphocytic and the other one is leukemia. So chronic sounds exactly like what it is, in that it's a bit of a slower, tedious process rather than something that is quick and fast. Lymphocytic just tells us the type of cell, and leukemia tells us that it's a leukemia, which we'll talk about a little bit later in terms of what that means. And the important part is that these are started off by B lymphocytes, which are a type of cell in the body, which we break down to B and T cells, and B cells just mean they're made in your bone marrow. Now, I'm a leukemia specialist, so of course it's important for you to know that there are all kinds of leukemias. They come in all flavors, but the main two flavors are going to be sort of this acute and chronic scenario, of which today we're going to be talking mostly about the chronic. Now, SLL is just a category under CLL, and all it's saying is that beyond the cells in the bone marrow being affected, you also have lymph nodes affected. That's all that differentiates. Now, as we talked about, the first letter is chronic, and therefore CLL is very slow developing. It's an ongoing condition that people will live with, oftentimes for many years in their life before we honestly need any kind of intervention. However, of course, because, as we said, leukemia comes in many flavors, it not only comes in many flavors, but every leukemia is special to itself. And in some ways, sometimes some leukemias grow faster than others. And most people will eventually need to be treated at some point or another, but there's currently no cure for CLL. Just as there's no cure for diabetes and there's no cure for hypertension, we manage these things with medications and interventions, very similar in this case as well. So key terms here to talk about, well, one would be anemia, which basically just says, your bone marrow is going to make three main kinds of cells. It makes your white cells, it makes your platelets, and it makes your hemoglobin, which is what makes blood in your body and oxygen to circulate. So when that hemoglobin is low, we get anemia. That's those low red blood cells. Chronic, which again, we talked about now ad nauseam. Basically, the point here is that this is a slowly progressive disease. Leukemia, as promised, which I said we would talk about, is simply when one of the cells that are in the bone marrow, specifically in the white cell category, starts to grow incorrectly. Now, lymphocytic is that specific type of white cell. So white cells also break down into multiple categories, of which one is lymphocytes. Marrow, we already talked about, is basically your bone marrow. And that is basically the factory of all of these cells. Now, how common is CLL? Interestingly, it's actually the most common type of leukemia in adults. It makes up about a quarter of new cases. That's about 21,000 new cases in the United States per year. However, it is pretty much a disease mostly of the elderly. We usually see it in the 7th decade. It's rarely seen in people under age 40 or in children. Of course, we have still seen cases like that, but it's not the norm. And many patients who have CLL actually don't have any symptoms at all. Oftentimes patients will come to me and say, I didn't feel a thing. You should have caught this sooner. What if I'd come to the doctor sooner? And that's the whole idea of CLL. It's very much an indolent disease, usually from the get-go. And then progressively over time, people may develop symptoms. And those would be things like fatigue, weight loss, drenching night sweats, fevers, and of course, low counts. So anytime your bone marrow is affected, any of those cells that we talked about can be affected. So it wouldn't just include your white cells, but also your red cells and your platelets. As far as diagnosis, again, we said some people don't even know they have symptoms at all. Oftentimes people are coming in to see their doctor just for some other thing or for a regular checkup, and we'll find that they'll have very elevated white counts, which then pushes us to look forward to see what type of white cells are these. And then we do special tests in the laboratory that help us find out whether or not this is CLL. I'll talk about that a little bit later down the line. But for now, moving forward to treatments for CLL, there are many treatments, but again, this is a slowly progressive disease. So generally in the beginning, we have this watch and wait approach, which is basically to see what does the white cell count do? Does it keep increasing very quickly? Do the other cell counts get affected? And do patients develop symptoms? Usually, until any of those things happen, we do not want to activate any kind of treatment. Of course, watch and wait can be a very anxiety-provoking place to be. It feels like you're doing nothing with this growing cancer inside of you. But studies have actually shown us that patients do much better when we go forward with watch and wait rather than immediate intervention. We always have to consider the risk and benefit of the side effect profile, and of course, the side effects that can be long-term from chemotherapies and other therapies as well. As far as coping with watch and wait, of course, again, it's very anxiety provoking. So it's important to ask questions continually to your physician. Make sure that you're writing notes. Make sure that you know what signs and symptoms to look for. Make sure that you're using activities that can help you decrease your stress, and know that it's normal to have these types of fears. Of course, whether or not you're doing treatment, but specifically when you're not doing any treatment at all, knowing that there is a disease process at play and you're not doing much for it, you have to understand why we're not doing anything and the fact that this will likely be a better outcome in the future. So when do we decide to treat or not to treat? So for the most part, we base this off of the stage of the CLL, much like we stage all other cancers. It has a stage 1 through 4. The difference is, unlike what we're used to hearing when we hear the word stage 4, we think of a disease that is going to lead to our demise soon. That is not the case in CLL. People will live with stage 4 disease for many years. The stages simply mean how much of the body is affected by the CLL. So in stage 0, we only have elevated white counts, whereas in stage 2, we'll have the lymph nodes affected. In stage 3, we're going to have an enlarging spleen, and stage 4, our cell counts will be affected. Now, sometimes you'll still have stage 0, but you'll have what we call B symptoms. And those are things like the fevers, night sweats, weight loss, and fatigue. And those might actually activate us to start treatment when they start to affect quality of life. As far as the goals for treatment, so one of those would be if a patient is having very quick increase in their white cell counts, we may activate treatment to bring down that white count. The second thing is if, of course, these symptoms are getting in the way of quality of life, we would want to activate treatment in order to help with that as well. Now, unlike treatment for some other cancers, CLL we are not using to cure disease. We're just trying to keep the disease at bay and ideally prolong survival. As far as treatment options, as we said, currently there is no cure. Now, again, I'm not a big fan of the term no cure because we have many diseases, again, such as diabetes and hypertension, which there is no cure for. But understanding that these are a chronic disease that you are going to be dealing with for the duration of your lifetime is very important. And that is sort of how we decide when to activate one step to the next, because essentially the goal is to prolong that lifespan as long as we can. So there are many types of therapies that we use. We use immunotherapies, chemoimmunotherapies, targeted therapies, and many new treatments. Now I'll talk a little bit about which of each of those things will mean a little bit down the line. Now, when we're planning for treatment of CLL, again, we already talked about the stages of CLL. This low, intermediate, or high risk is based off of the stage that we're in, the side effects that we have, and oftentimes things like genetic mutations that are involved in the disease process and how significant the symptoms that a patient has are. And of course, if you're young and you're, on the lower age spectrum, we tend to want to activate treatments a bit sooner because generally those diseases tend to be a bit more aggressive. Now, chemoimmunotherapy is a combination of both chemotherapy and immunotherapy. Now, chemotherapy, we're all used to hearing. I like to describe that as kind of like a grenade. It's not very bright. It goes into the bloodstream and sort of kills all cells. It's not able to look at cells and say, hey, you're a cancer, you're not a cancer. But fast growing cells in the body are going to be attacked by the chemotherapy. Immunotherapy and other therapies, such as targeted therapy, which we'll talk about in a second, I refer to those more as snipers. They're a little bit more specific. They're able to go in the bloodstream and be a bit more selective about the types of cells that they attack. Now, in the case of CLL specifically, we've found that our immunotherapies actually work better with a little bit of chemotherapy in conjunction, and that gets us a bit farther in terms of keeping the disease at bay. Now, some of these combinations that we use, FCR used to be the most common combination. It is a bit strong in that it brings down cell counts for an extended period of time. And so in our patients who are a bit older or might have a little less reserve, we tend to use bendamustine and rituximab. Chlorambucil is also used as well, as is obinutuzumab, although to be honest, chlorambucil is not as commonly used as it used to be. And then targeted therapy, so like we talked about, unlike the chemotherapy drugs, which pretty much attack anything growing fast, targeted therapy is a little bit smarter. We have multiple types of targeted therapy. I won't go into the pathophysiology of how each of those work. The ones that are sort of the frontliners currently in this disease process are venetoclax and ibrutinib, although acalabrutinib, idelalisib, and duvelisib are some of the newer ones that are on the horizon. Now, immunotherapy, these are, as we talked about, one of our more targeted therapies. They tend to take advantage of the immune system and help to fight sort of these abnormal B cells that are growing. They work in different ways, but for the most part, they target specific, little markers that are on the cells themselves, on B cells specifically, and help us to attack those cells rather than any cell that's growing quickly. Now, stem cell transplant is actually not commonly used in CLL. In the past, we used to trigger it a little bit more quickly, but now that we have so many treatments that we can use, the honest to truth time that we would use it would be if someone was much younger or has blown through many treatments for CLL without much response. Now, stem cell transplant, I'll take just 2 seconds only because, this is my area of expertise and I love it so much. But basically the idea is that we use therapies such as chemotherapies, immunotherapies, whatever it is that we need to completely clear the bone marrow of any of these abnormal cells. And then, just like a blood transfusion, we infuse stem cells from someone who has donated to us in order to grow a brand new bone marrow that will no longer have any of this cancerous cell. So now we'll move on to CML, which is chronic myeloid leukemia. This is very much similar to CLL in two ways. One, it's chronic. So again, it's a slower growing indolent course. And two, it's a leukemia. So it's an abnormal cell that starts growing from the bone marrow. The difference here is the lineage. So this is a myeloid cell rather than a lymphoid cell, such as the one we talked about in CLL. But in addition to that, CML is a little bit special in that once we mapped the human genome and got a better idea of how genes work, we realized that this is actually a very specific mutation that happens in CML called the BCR-ABL mutation, where one piece, the BCR gene from one chromosome, comes from another piece of another chromosome with the ABL gene, and they combine, and they basically create an abnormal cell, which is the CML cancer cell. So the key terms here would be the BCR-ABL, blasts, leukemia, and the Philadelphia chromosome. We talked about BCR-ABL. We did not talk about the Philadelphia chromosome. So Philadelphia chromosome is those two pieces of chromosomes that come together to create this BCR-ABL combination. And of course, leukemia we've already discussed. Blasts are basically the abnormal cells that get created that are pushed out from our bone marrow too quickly. I like to call them baby cells, which starts with B, just like blasts. And because they're so young and they're not ready to be out in the bloodstream, they're sort of big, undifferentiated, and sticky, and they can cause problems in the bloodstream. Now, symptoms of CML, just like CLL in the beginning, oftentimes patients may not have any symptoms at all. We diagnose this through routine blood tests, or sometimes patients present with some other medical issue. We do a blood test and we find their white count to be high. If people do have symptoms, they're very similar to the B symptoms that we talked about in CLL. Things like losing weight, fevers, night sweats. The difference here is sometimes people can get a very significant increase in the size of their spleen, which can cause pain and sometimes fullness after eating a very small amount of food. Now, diagnosing CML can be through physical exam, although the findings we would see here are usually in much more progressed disease, things like that enlarged spleen that would be able to palpate. Otherwise, lab tests are very important here, and specifically this molecular testing is the most important. And the reason for that is that we can actually find this BCR-ABL gene, which is diagnostic and specific to CML. Now, those blast cells that we talked about are important for one reason, and that is it helps us to put CML into phases. So unlike CLL, which has stage 1 through 4, CML is basically staged into 3 stages. Chronic is basically the earliest phase, and that's where we don't see any blast cells when we look in the peripheral blood or if we were to look in a bone marrow biopsy. Accelerated, however, we will have a number of blasts, sometimes the spleen will increase, and blood counts are a little bit more wonky. Blast or blast cell crisis is basically the equivalent of an acute leukemia, and this happens when the number of blast cells is more than 20%, either in the bone marrow or in the bloodstream. There are a little bit more finer definitions, such as other specific types of cells like the basophils, but I won't go into those details today. As far as monitoring treatment for CML, one would be that we use the complete blood count with a differential. Complete blood count basically tells us about your white count, your hemoglobin, your platelets, whereas the differential tells me exactly what flavor the white cells are. Cytogenetics and FISH is how we look at chromosome arrangement and the mutations that might be evident in those chromosomes. And PCR is what we use in order to get an idea of the amount of the abnormal protein that's being created in these cells. So the BCR-ABL protein is what's being produced by that Philadelphia chromosome. As far as treatment for CML, so we use targeted therapy, stem cell transplant, chemo and immunotherapy, and clinical trials. Targeted therapy here, very similar to targeted therapy that we talked about in CLL, in that it's much more specific than we see chemotherapy. However, it's specific to that BCR-ABL transcript. And interestingly, it's actually the very first targeted therapy that was ever created in the history of cancer was Gleevec or imatinib, which was used in CML. And what we can see with these targeted therapies is that we are able to completely get rid of that BCR-ABL protein being created in the bloodstream. These are pills that you take by mouth. They can be affected by multiple things, and each of those TKIs have their own side effect profile, which we take into consideration when we give them to our patients. Additionally, they're sort of like an entire armamentum of ammunition. We use one. If that one stops working, when the cancer gets smart and grows a mutation, then we can move on to the next one. As far as stem cell transplant, again, very similar to CLL. These days, because we have so many TKIs and so many treatments in our back pocket, we don't tend to activate stem cell transplant as quickly as we used to in the past. The process of stem cell transplant in CML and CLL is much the same. Sometimes the conditioning regimen, or basically the chemotherapy or treatment that we use to prepare the bone marrow, would be a bit different. And of course, that's because the process and the actual cells being affected in the bone marrow are different. Chemotherapy is not commonly used in CML because we have these TKIs and they do such a great job. However, sometimes when it's very out of control, we may use things like hydroxyurea in order to debulk or bring down the number of cells a bit more quickly while we wait on our results, our molecular results for other tests that we run in the diagnosis process of CML. Immunotherapy, again, is not something that we use as often. We do use it sometimes in our pregnant patients these days, given that they cannot take the TKIs, but otherwise interferon use is very much a thing of the past in CML. As far as clinical trials, these are studies that are done by doctors to test multiple things. So they either look at new drugs or treatments. Sometimes they look at drugs we already know, but we combine them with different things, or we use them in different ways. And other times we are basically trying to look to see what the side effect profile of these combinations might be, in addition to whether or not they work at all. Okay, so I've talked about a bunch right now. I just wanted to take a break 1 second and see if there are any questions about what I've said so far. All right, then let us communicate now together and go on to communicating with your healthcare team. So choosing your healthcare team is very, very important. I tell all my patients, this is a time to be very, very picky. We're picky about where we eat. We're picky about where we buy clothes. We're picky about everything. This is a similar place that you need to be equally picky. The reason for that is this is going to be your care team for a very, very extended period of time, if not your entire life. And you need to make sure that your goals, how you feel as a person in terms of your disease and how you'd like to approach it, are something that your provider and your provider's team understand well and are able to be in the process of helping you achieve those goals. So after you're diagnosed, your doctor is likely going to discuss with you some of the treatments that might be best tailored for you. They might ask you what you want to do about those possibilities and sort of which one you feel fits the goals of your treatment best. And so some planning tips for that, it's important to think about your values and goals before you enter any kind of treatment. I always say that if I were to ask my mom versus my dad, I would get very different answers in terms of how they want to approach their treatment, what they see in terms of the future of their treatment in all areas. So those would be things like your physical health and well-being, how you're going to relate to your family with those interventions, work, school, community, etc. I also oftentimes tell patients it is very important to get a second opinion. We do not feel insulted. We do not feel like you don't respect our opinion. If anything, it's very important so that you feel that you have actually gotten all of the answers that you're looking for, overturned every stone possible, so you don't think back later, I wish I would have asked about this, or I wish I would have looked into the next thing. In addition, there are lots of places that we can get information, like the Cancer Information Service of the National Cancer Institute or the Leukemia and Lymphoma Society, which can basically serve as other resources to sort of help continue not just a second opinion, but understand the process going on to understand both the first and second opinion. Now, coping with side effects. So you have to be prepared for the fact that, of course, not only has everything changed in terms of carrying this diagnosis, but now you're going to be getting treatments and things that are put into your body that are the first time you're being exposed to them, and that you likely may be on for a very extended period of time. So it's very important to recognize that every body is different, everyone reacts differently, but there are sort of, just like those commercials where it starts off, you think you're taking a medication for one thing and you have the possibility of a million other side effects. Doesn't necessarily mean that any of those will happen, particularly doesn't mean that all of them will happen, but it's important to be prepared for what could be ahead. Now, common side effects that we see in patients anytime that we give, treatments, but in addition, treatments to patients who have CLL or CML. This slide says CLL, but in CML, it's the same, that the disease itself can actually give patients fatigue. It can also give you a higher propensity for infection. CLL a bit more than CML, just because those lymphocytes are responsible for creating some of the antibodies that help our body fight infection. So otherwise, there are things like diarrhea and constipation. These tend to be more from the actual treatments that we're giving for both CLL and CML. And depending on sort of which side of the spectrum you fall, there are different interventions that one can take. Diarrhea, when you're keeping up with fluid, avoiding caffeine, which for me would be very difficult. And then, of course, having small, frequent meals. Whereas constipation, we use a lot of different medications for this, but also, drinking things like hot beverages and herbal tea can sometimes be helpful, staying active, increasing your fiber intake, etc. Trying to do basically as many things as you can from all different sides to manage these side effects can be quite helpful. Pain and insomnia. So, pain is not as common in the earlier phases of disease for both CLL and CML. Things like that enlarged spleen can sometimes cause patients to have some fullness in the abdomen that can be painful. But otherwise, both of these diseases tend to not be very painful for the predominance of the disease. Insomnia can be from multiple things, sometimes just from the diagnosis itself and the anxiety that comes with that. Sometimes the medications that we give, specifically things like steroids, sometimes. And then, of course, so you want to combat that with keeping away from things that worsen not being able to sleep, like caffeine or alcohol. Exercising regularly is important, but I always tell my patients, make sure you're not exercising at night because that tends to keep people awake even later. Mouth sores, these can sometimes happen from both the disease and the treatment. We have lots of different mouth care that we give to patients to use, things like rinses and making sure that you're keeping your gums and your teeth very clean, but also handling them with care. Rashes and skin changes can be both from the disease, but usually is more from the interventions that we give, especially some of those monoclonal antibodies. People can have reactions to them. So we recommend at those periods, we oftentimes will give things like steroids that are topical. Other times we recommend doing like an oatmeal bath or a sitz bath. But otherwise, we try to keep patients to moisturize their skin, always wear sunscreen. And when you're outside, if you're going on a hike or things like that, just keep yourself from having exposure to anything extra on your skin than necessary. Nausea and and vomiting, to be honest, I think we've gotten a lot better than this in the cancer field. We have quite the armamentum in terms of anti-nausea drugs, but at the same time, there are other things that can be quite helpful. Ginger has been shown to be helpful. There's ginger pops, ginger teas, ginger chews, you name it. Also, trying to eat a small amount of food every couple of hours, just so that acid in the stomach isn't roaming around. That can be quite helpful. And then, having
Okay.
Oh, wasn't sure if there was a question. Okay. And then, the other side effect is low blood counts. Now, again, this can happen from the disease itself because of the effect on the bone marrow, but oftentimes will happen with many of the interventions that we give. One of the things when platelets get low is that patients can get bleeding, specifically bleeding of the gums, or they can get easy bruising. Anemia can actually make people quite tired, especially in those patients who might have things like COPD or lung issues, or who might have cardiac issues. Anemia can be a bit difficult in terms of energy levels. Now, palliative care, this is a term that I don't think is very commonly used, especially in the beginning part of our treatment paradigm, but I think is slowly and surely becoming more important in the cancer treatment realm. So this is really a newer concept. It's actually a fellowship that's less than a decade old. But the idea here is we're really focusing on keeping patients comfortable and basically supporting them in all the ways that we can, whether that may be in specifically to the disease by continuing with anti-cancer therapies. Other times it may be things like social support, maybe things like symptom support. Sometimes they're better at pain management. They're able to give certain medications or certain interventions that can be helpful. But the idea is to sort of bring together all of the different teams that are involved in your care and to help continue support from all different directions. Now, a misnomer here, oftentimes patients will confuse palliative care with hospice. Now, hospice is under the umbrella of palliative care, but does not describe it as a whole. Hospice is sort of more end of life, where patients oftentimes will come off of treatments and go home to remain comfortable. And the palliative care team who's been taking care of the patient even before that will oftentimes be involved in that sort of transition of care. Now, living with a chronic blood cancer, the end of treatment is not the end of your journey. So just because you're not getting chemotherapy does not mean that your journey has ended here. Things you can do as a CLL and CML patient. So you can go to your follow-up doctor visits. You can make sure, this is very important actually, is keeping your health insurance. Oftentimes we have to keep up in terms of, especially if people are on, disability or other things. You want to make sure you keep up to date with your health insurance, especially because many of these medications are much, much more expensive than anyone really anticipates. You also want to sort of do your side of things to make sure that you're maintaining good health and eating a healthy diet, limiting consumption of alcohol, exercise. I do want to mention that eating a healthy diet, many patients always come to me and say, I'm staying away from sugar because sugar feeds the cancer. And I want to take this moment to reiterate that sugar does not feed cancer. And you are more than welcome to eat sugar so long as you don't have diabetes or other issues. In those instances, I would say to stay away from it. But for cancer specifically, sugar does not play into that. And then universal challenges of living with cancer. So of course, anytime we hear the big C word, that affects people in many ways, including loss of hope, feeling that you don't have a sense of control, feeling very uncertain about what the future holds, and this unwanted loneliness, regardless of the number of people who are around you. It feels as if you're the only one who is really having to feel the actual effects of the cancer itself. Now, that's sort of a general, unfortunate truth for patients who are undergoing cancer, but there are more unique challenges that we see specific to these different types of blood diseases. With CLL, patients will oftentimes, have to deal with this watch and wait. That in and of itself is very specific to this disease, and can cause a lot of anxiety. And it's kind of difficult to explain sometimes to family, why isn't treatment being started? Why do you have cancer and they're not doing anything about it? And that can oftentimes become very exhausting. Also, this sort of, this conversation about lack of a cure, hearing the words that there is not a cure for your disease is a hard one to hear. But again, this idea that you should approach it more like a chronic disease is one of the things that I think has really changed the face of cancer, specifically in both chronic CLL and CML. Now, living with chronic cancer is not really about going back to your normal life necessarily. It's basically just a new normal. And that is, oftentimes true for many different things. Again, things like hypertension and diabetes would have the same type of effect. You sort of have to tailor your new diagnosis to this new lifestyle. And oftentimes, patients start to go on a health kick with that. You start losing weight in a very healthy way. And in fact, sometimes it can actually be a positive change in life, or at least have a positive component. And having some kind of support is quite critical. Support groups can be quite helpful so you don't feel so alone. Spiritual groups and spiritual support can be helpful. Family, friends, community, basically anyone in your inner or outer circle that can help you sort of, combat some of these emotional issues and difficulty with a new diagnosis can be very helpful. So every time I tell a patient to try yoga, I get very different responses from everybody. But yoga, mindfulness, these sort of exercises, they can be found on any YouTube channel. You can pick sort of someone that you feel you can trust, that bond with, and can be done at the safety of your own home, especially these days with COVID. You want to also make sure that you're keeping, communication open with the people around you so that they can be aware of when you might be going through a hard time or when you might need a little bit more support in your treatment process. We talked about CLL in terms of challenges that are more unique to CLL. In CML, we don't have as much of this watch and wait realm as we do, but we do, have this idea that you're living with a chronic cancer, sometimes without really any symptoms, which feels a bit weird because you're constantly having to come to, at minimum every 3 months, we have our patients come into clinic. So it's a constant reminder that you really do have this disease, even if it's being quite well managed with this TKI, which is just a pill. Additionally, oftentimes patients can have fatigue, especially if they're becoming anemic or just from the medications themselves. So finding a new normal with that fatigue can also be a bit of a challenge. And again, the same applies for CML as it does with CLL in terms of finding that support that you need, trying to stay active, and the same type of interventions we just discussed. Now, legal tools, I'll just, briefly talk about these because I think these are also equally important in terms of feeling like you have a sense of power over your life and your future. A living will or advance directive really helps us as your physician know what kind of Medicare you want in a unfortunate situation where you may not be able to speak for yourself. A durable power of attorney grants a person who will make health decisions for you if you are unable to make them yourself. So that's more sort of medically specific, whereas a living will oftentimes have things like your finances, etc. Will also include sort of your wishes in the future. A financial power of attorney will actually allow for this person to not only make healthcare decisions, but to also make decisions about your finances. Now, DNR or do not resuscitate, this is sort of more important when we get to more close to end of life with our patients. And this is just basically saying whether or not in the event that something should happen in terms of, your heart's not working anymore, or you were to need help with a ventilator to help you breathe, in terms of what kind of heroic measures or interventions you would want to have happen. And then a will, as we just talked about, basically designates more the financial side of things. Especially if there isn't another parent alive, or if you're trying to pass, specific things down to specific people. As far as in the community, there are many cancer support community resources. I won't read all of this through, but would definitely, consider the cancer support helpline is a very good one. I also think that the NCCN website can be helpful. There's an entire section that's specific for patients. Also, the Lymphoma and Leukemia Society, as we talked about before, can also be very helpful as well. And then the Cancer Experience Registry. So this is a research survey to identify and understand sort of our emotional and social needs that are unique to patients in their CLL experience. We do use sort of similar registries for different types of cancer, but this is a confidential and secure way to sort of add to, our ability to understand exactly what patients are going through so that we can do a better job of not just advocating, but also improving quality of care. And how to join, this is the website, the cancerexperienceregistry.org. You basically go onto the website and register with 3 different steps and then fill out the survey to share your experience. There's also, lots of grassroots movements. These are sort of helping to ensure that our patients have access to the kind of care that they should have. And it includes social and emotional support. The website here is also included on this slide. And I think they might be able to send that to everyone who is here today as well. There's also mylifeline.org. This also, is something you can share with your family and friends. It will kind of help them to also be involved in terms of knowing, how you're doing, what you're doing. You're able to kind of keep in touch with multiple people at once. They have also things like discussion boards and care coordinators. And of course, there's very a significant amount of privacy controls here as well. So this is all ensured that people who are commenting, etc., are following the same privacy rules. So at this point, I feel like I have talked everyone's ears off, and we'll open the floor to any questions, comments, observations, however I can be helpful.
Well, first off, thank you so much, Dr. Pourhassan. You're so right. It was such a content-heavy workshop, and yet you made it so approachable and digestible. So we really appreciate that. Dr. Pourhassan's information was put into the chat, as well as information about the City of Hope Leukemia Program. If you just scroll up in the chat, I think it was the first comment there. So I'd encourage you to go visit her profile and City of Hope's Leukemia Program page. Also, I'm just going to drop into the chat. We have a workshop evaluation for you to complete after you leave tonight. That's really helpful for us in knowing what you would like to see more of at CSC. After this workshop, I'm also going to send an accompanying pamphlet that outlines a lot of the information that Dr. Pourhassan covered in this presentation. So you can expect that email from me a few minutes after the workshop. But now I would love to just open it up for chat, or for questions rather. Feel free to unmute yourself to ask a question, or you can send a question to me in the chat and I'm happy to read it out loud for you.
I'd like to speak. My name is Tess Sandoval, and first of all, I'd like to thank you, Dr. Pourhassan, for a very thorough overview of everything here. My key question is, I've been diagnosed with multiple myeloma, and I don't, is CLL, SLL, or CML what I have?
So no, so these are actually different diseases. So multiple myeloma is also a chronic disease, also very similar to CML and CLL in that there are many interventions that we use to treat it as a chronic disease. It also starts in the bone marrow, similar to these disorders, but it is the type of cell that's affected that's different. Now, also how it affects the body is very different. Multiple myeloma can affect things like the kidney. It can affect things like the blood cell counts, just like it does in these disorders, but mostly anemia is more common, what we see in multiple myeloma. You can also have, bone effects with multiple myeloma. People can get lesions in the bone, etc. And then I think the calcium levels can also sometimes be elevated. So those four are called actually CRAB criteria that go with multiple myeloma. The difference with multiple myeloma that I think would be much bigger is that we actually use stem cell transplant a little bit sooner in multiple myeloma than we would in these two diseases. And the type of stem cell transplant that we would use is very different. We actually get stem cells from the patient themselves and give you your own stem cells back rather than borrowing stem cells from someone else. But these are definitely.
I already had that, so I'm not sure I should have been in this. It was very interesting, but the whole time I was wondering if this was really for me.
I guess not.
Thank you very much for a very thorough review.
No problem.
Hey, no, it was interesting. Thank you very much.
No problem.
I did get a question that came through the chat, just kind of asking about the future of treatments for CLL and CML, if you have any thoughts about what may be coming down the line.
Well, with CML, we do have actually just, I want to say 2-3 weeks ago, a new TKI came out called asciminib that got FDA approval. We are definitely working on more TKIs just because what ends up happening over time is these CML cells get a bit smarter and they become resistant to the TKI treatments that we're using. And so we had to outsmart the disease by finding TKIs that sort of attack the protein from different corners of the protein and different pockets of the protein. So most of the research that's being done in CML is targeted toward making more of these TKI therapies rather than finding a different type of therapy that would work, just because they've been so successful and so specific to this gene mutation. CLL, on the other hand, is not like CML in that it doesn't have just one specific gene that's affected that we can target, but definitely the immunotherapy world and the targeted therapy world is expanding. We are still a bit more reliant on chemotherapy, more in the CLL world than the CML world, but I think over time, as targeted therapies and our immunotherapies improve, we'll probably start to filter less and less chemo.
Thank you. Other questions? People can feel free to unmute themselves, type a question in the chat.
Yeah, I have a quick question.
Sure.
Hello?
Hi.
Okay. Hi. I got diagnosed with leukemia about 9-10 years ago, and I'm about 9 years past the prediction of being alive. I'm curious because I've had about 4 friends that literally took out their root canal teeth, and literally one had multiple sclerosis, one of the more difficult to deal with autoimmune, and the others had were already stage 4 cancer. The doctors had pretty much told them that there was nothing more that they could do for them. They'd already been through the chemo, the radiation. All of them are still alive, totally cancer free. Based on the cancer in which you were talking about today, and then also too, I've just cut back like on dairy, sugar, and meat, but I don't by any way do any sort of perfect diet. Are these things that you've explored? Because on my hematology appointments and whatnot, it's almost like when I bring it up, I'm bringing up some sort of a bad thing, but there is, a lot of, I had now probably a total of 8 people that I've known that have literally gone the whole route with the doctors, and then, been in hospice, and now they're all completely cancer free. Is that something that you've ever heard of, or what are your thoughts on that?
That's a great question. So first and foremost, I think that, sometimes we're comparing apples and oranges. And the reason I say that is that cancer in and of itself is quite a huge, huge world in terms of how it's described. Not all cancers are alike, not all stage 4s are the same. And specifically, blood cancer, solid tumors, these become, completely different avenues with completely different outcomes. And I think that oftentimes, because we as providers don't do the best job in terms of equipping patients with the knowledge of exactly what disease they have, sometimes we're told one thing and it's actually something else going on. So I've had patients, for example, who will come to me and say, well, I have bone cancer. And then I will go through the records and I'll find out, no, this person had breast cancer that metastasized to the bone. And there's a very big difference between how long a patient with bone cancer is going to live versus a patient who had breast cancer that goes to the bone. And so each of these different types of cancer has their own sort of prognosis, their own outcome, and their own ways that we approach those with treatment. So in terms of the type, of disease that you're, these people that have had cancer that are now cancer free that you've heard about, I can't really speak to the type of cancer that they have and what was expected and what actually the outcome was. What I can say is that one of the biggest mistakes we make as physicians is looking into our crystal ball We don't really have one. We do have studies specific to disease types that we can look at to say, based off of, X, Y, and Z, we predict that the average lifespan is going to be whatever number. As far as diet is concerned, actually, there are a lot of, especially Eastern medicine interventions that have been used specifically in the cancer world and many other types of diseases. I myself actually did a rotation in China in Eastern medicine there and saw them curing many diseases with Eastern herbal medicines and helping patients with things like anemia. So for example, when someone is anemic, if it's from iron deficiency, if we replace that with iron, you can help their anemia. Now, in terms of there being something diet-wise that can cure cancer, we have certain things like vitamin D and aspirin, which have been shown in colon cancer to decrease the risk of reoccurrence in patients who have been cured of their disease. But we have not yet found anything dietary that would cause a full cure of any type of cancer as of yet. But that doesn't mean that there aren't things out there that can be helpful for some of these side effects and symptoms incurred by the disease.
And do you, just out of curiosity, do you, because it seems in Western medicine that the only thing that is allowed to remain within the body after it's been identified as being a dead member is the root canal, just because of some of my rich relatives back in the past that didn't like the stigma of a missing tooth, as it was a sign of being poor. But everything else, your appendix, if you get gangrene, if you get frostbite, they remove it. Whereas the root canal, they've yet to do a successful root canal where the whole idea is to bring out all of the nerve endings, but to date, they've never had a successful root canal where it isn't seeping like deadly toxins back into the person's bloodstream. Is that something that that you've looked into, or something that you have a thought on either way, or is that just something that you haven't really researched yet?
Well, I had a root canal and I don't have anything in my bloodstream, so I'm patient X.
Thank you, Dr. Pourhassan. We do have one more question that I want to get to really quickly.
Sure.
Somebody in the chat said, hydroxyurea, what long-term side effects might be seen here? I have myelofibrosis and have been on approximately 1,500 milligrams daily for 3.5 years.
Right. So hydroxyurea is actually a very interesting drug. It's one of those that's not the brightest, but does a great job. It goes and it actually affects the bone marrow in terms of how it produces cells and kind of calms it down so that people aren't producing a bunch of bad cells. Short term, some of the side effects people can get are, at higher doses, they can get mouth sores, they can get nausea, vomiting, GI upset. But long term, there's been a lot of studies in terms of, one thing would be skin cancers are something that are increased in the use of hydroxyurea. And for that, we oftentimes tell our patients to use sunscreen. There is sort of this thought that sometimes hydroxyurea may lead to an increase in taking a patient from chronic leukemia to acute leukemia, but it's not actually very robust in the literature. And either way, we prefer the risk versus benefit. The use of hydroxyurea to control the disease outweighs the possibility, which is very small, of these secondary leukemias that have been seen. But for the most part, in terms of big side effects, I would say that the main one would be sort of these skin changes that can be seen that can be cancerous.
Great, thank you so much. I just put in the chat the feedback form for everybody to fill out if you have an opportunity. Just want to thank Dr. Pourhassan again for this wonderful lecture tonight and for spending so much time answering our questions and answers so thoughtfully. Thank you all for attending and participating, and we look forward to seeing you all at our next workshop.
Wonderful. Have a great day, everyone.
Thank you very much. Great presentation. Thank you.